third abstract here talks about managing patients with low-risk MDS in a large U.S. community oncology practice. And the focus here was on patient outcomes after ESA treatment, including failure. So I can actually see if I can summarize this for you, and then we can get your input on this. And again, this is sort of real-world data. It's done in a retrospective fashion. This comes from Florida Cancer Specialists and Research Institute that have been treated with ESA. And obviously, the idea here is to look at those who had received only ESAs, and there was about 350 patients. And what's interesting is to see what was the hemoglobin level at the time of ESA initiation. So the hemoglobin level at ESA was less than 8 grams in only 12.5%. So, and you wonder if this was because people who require transfusions were perceived as people who would be less likely to respond to ESA. It's possible, but the majority of patients received ESA in this cohort when they had a hemoglobin between 8 and 10. And those, again, I would question why would someone with a hemoglobin greater than 10 grams receive ESA, but nevertheless, there were 23% or almost 24% that were included in that category. EPO level, which is, again, very important, was below 200, that rather, in the majority of patients. So you know that this sets them for potential better response to ESAs. And also importantly, 80% of those people did not require red cell transfusion in the 8 weeks prior to ESA initiation. So essentially, maybe 20% did. So according to the abstracts, only about a third of the patients had ESA response, whereas almost 70% did not. And so what happened to those patients afterwards is that the great majority of those patients continued, such that 60% of those people remain on ESA almost a year after ESA failures. And so I'm just curious, what do you guys think about the results of this particular abstract? What does that speak to? Is this simply a manifestation of the fact that we had nothing else to offer patients, or are we like so married to ESAs, it's so difficult for us to consider an alternate option, even when the failure definition has been met?
Yeah, I thought this was a pretty interesting abstract, and interesting especially because Florida Cancer Specialist is the main community practice that actually refers patients to our clinic at Tampa General, and so we do work a lot with this group and a lot with the providers. But what I found interesting was it really kind of shows what life looks like outside of academic practice, right? And so, most of these clinical trials were done for transfusion-dependent patients, but the reality is the majority of patients that are getting started on ESAs are transfusion independent when they're getting started. And the majority of patients are getting started at higher hemoglobin levels than what you would expect to require a transfusion, oftentimes higher than what you might even expect for a patient to be symptomatic from their anemia. And so I thought it was interesting that sort of showed that population, and then, even in a patient population that had, non-transfusion independence, relatively low EPO values, a low number of them actually responded to ESA based on whatever the definition they were using for ESA response, which is a little unclear to me. Because like you said, a lot of these patients did stay on therapy for a very long period of time. And I think, that's the challenge when you start patients when they're not transfusion independent. It's a little harder sometimes to meet the, outcomes, because most of our outcomes are based on transfusion dependent patients. And so, yeah, I thought it was an interesting analysis. It just a lot of different points of what we kind of see in community practice as patients get referred to us. I think the nice thing is now we have a lot of new options for these patients that are, the high number of patients that are ESA refractory that were shown in this cohort.
Yeah, I thought this was, I agree. I thought this was really good real world data. though it was only one practice. But I thought it was a good number of patients, about 350 patients over 4 years. And it really raises this question about when to switch, from an ESA to luspatercept, or when to, is early intervention worthwhile in these patients, some of these patients who, lose their response and keep going with the ESAs, or could there be some utility for the addition of luspatercept in these patients as well? And so that, those questions are definitely raised. I think it also, gets us thinking about how to sequence the drugs that we have available now and that are coming available. ESA first, luspatercept first, the combination of these two things. The other thing about the kind of looking at this data is that, we sometimes in clinical practice have patients who you start on an ESA kind of when their hemoglobin is declining, and it doesn't necessarily seem like you're getting a response, and you stop the ESA, and their hemoglobin starts to decline again. And so it's almost as though you've kind of warded off the continued decline of hemoglobin. And I think some of these patients may fall into that category. Again, would these patients benefit from the addition or, switching to luspatercept is the big question that this raises.
Yeah, I mean, again, I agree with everything that's been said, and it's quite interesting. I mean, I also wasn't very clear as to what their true definition was for a response to the ESA. I mean, are they actually looking for a 1.5 gram per deciliter increase in the hemoglobin?
That's what it was, yes.
Well, I mean, so if that's what it is, I mean, I think it's a little bit surprising in my view. I think the response rate is, in my mind, lower than what I expected. But then again, in clinical practice, I think we tend to look at perhaps, a 1 gram increase as being still a response. It's not a clinical trial response, but it is a response. And perhaps that's the reason in the clinical setting, they kept continuing on the ESA, even though they didn't really achieve that absolute 1.5 gram per deciliter benefit.
Yeah, I totally agree with what all of your remarks. And actually, you start to wonder if maybe we have set ourselves and patients to accepting stable disease.
Right.
So if you have someone who has hemoglobin of 9, you did ESAs, and the hemoglobin continues to be at 9 or 9.5, we all rejoice, right? So, but the point is, and what's interesting also for me is to see how little perhaps utilization of the IWG criteria there may have been in this instance, because I would imagine if you had some type of an assessment, a formal assessment that this patient isn't responding as such, and you probably would start thinking about what else to do. But again, I think we've all been in the same shoes, and you're happy with hemoglobin, but is there a better option out there for those patients? And I think that probably more real world data as time comes would probably be very helpful in that regard. Well, thank you very much for this. Very insightful. I was most curious as to what you thought about this one.
One last thing about this abstract, I do wonder if this is going to be somewhat of a moot point in the future. There is forthcoming data, looking at luspatercept plus EPO, and I think there was a letter to the editor to Blood Advances from the Moffitt group and David Solomon, actually, suggesting in this group of patients that they presented that patients may benefit from the combination of the two. And I'm curious to see what comes of that at this year's ASH as well.
Yes, that would be very helpful. And I think all of us, and to your point about people who have chronic kidney disease, that they are deficient in EPO, right? And so maybe there will be a patient subset that might benefit from the combination, but obviously thinking about something and making sure that you actually turn it into a reality in clinical practice is something we all have to work and struggle with, if you will.